According to the Arthritis Foundation, about 1.5 million people in the United States have rheumatoid arthritis, and nearly 3 times as many women have the disease as men. Today on Being Well, Dr. Chip Rowe from Paris Community Hospital Family Medical Center will be here to talk about RA, its symptoms, treatment options, and more. There's a lot of helpful information coming your way, so stay right here. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. AlphaCare, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. AlphaCare, compassionate professional home care. Additional funding by Jazzercise of Charleston. Orthopedic surgeon Dr. Chip Rowe has brought joints for us today for our discussion about rheumatoid arthritis. Thanks for coming over.
Thank you, Lori. I appreciate being here again.
It's been a few sessions since we've had you back, but we wanted to talk about rheumatoid arthritis because it does affect several million people.
It does.
We hear about arthritis in general, but there is a difference between RA and the more typical osteoarthritis.
There is.
Okay.
The arthritis, plain and simple, is just the wearing out of the joint surface. The joint surface is covered with cartilage that has very little friction. If that cartilage starts to break down, then you start to get friction. It doesn't function as well. In the most common form of arthritis, which is wear and tear or osteoarthritis, the joint just wears out with time. Whereas in rheumatoid arthritis, there is an actual active process that destroys the cartilage itself.
Okay.
And that's mediated through something that we call an autoimmune process, where for whatever reasons we don't completely understand, our immune system identifies our own cartilage or the linings of our joint, the synovium, as being abnormal and actively begins to attack it.
Okay.
And as a consequence, it destroys the cartilage.
Okay, so can you grab one of our models and actually show what's happening?
Visually, this happens to be a model of the knee. This would be the right knee. If you were to look at the ends of the bones, if you were to break the joint apart, it would have a nice, white, shiny, smooth surface. What gives it that appearance is that layer of what we call articular cartilage. With rheumatoid arthritis or degenerative arthritis, that cartilage undergoes change and it reaches a point where the bone is no longer completely covered with that nice, smooth, shiny white surface. It starts to become roughened and irregular, and that is a source of pain, limitation of motion, and deterioration of function.
Okay. So how does someone know if they have RA versus osteoarthritis?
Well, unfortunately, it's not a simple yes and no question.
Okay.
Rheumatoid arthritis is what we put into the category of a syndrome, meaning that there's not one specific thing that enables us to say you do or you do not have rheumatoid arthritis. There are a constellation of about 10 factors that we look at.
Okay.
Morning stiffness, swelling of the joint, limited range of motion, but then we will couple that with laboratory studies. The common ones are something called a test for a rheumatoid factor, which is positive in about 70 to 80% of people with rheumatoid arthritis. But there's 30% of people or so where their rheumatoid factor is negative. More recently, they've come up with a test called AC PA, which is looking for a different type of antibody. And that actually is a little bit more specific for rheumatoid arthritis. But then we also look at signs of inflammation, such as a sedimentation rate and a C-reactive protein. And again, in everybody who has rheumatoid arthritis, all of those factors are not positive. So we take those constellation of things, and if 6 or more of them are positive, then you're presumed to have rheumatoid arthritis. If 3 of them are positive and the rest of them are negative, then we kind of scratch our head and we look for other potential things like lupus or Lyme disease, or there's various other types of syndromes that can overlap with rheumatoid arthritis.
Okay, so it sounds like it's a little bit of a mysterious kind of disease in some ways.
It is, because we like to think that things are simple, but with rheumatoid arthritis, there's not 100% genetic relationship. So just because you have it doesn't necessarily mean that a child has it.
Okay.
They say that hereditary is a 50% factor in terms of whether you're going to develop rheumatoid arthritis. But I mean, the statistics today show that men, particularly who are heavy smokers, have a 3 times increased likelihood of developing rheumatoid arthritis than a man who does not smoke. So there are also environmental factors, and there's always been the debate whether there is some infectious cause, such as a virus, that triggers it, because we know that people who have Epstein-Barr virus, there's a relationship there with rheumatoid arthritis. So you're right, it is mysterious in that we can't really pigeonhole and say that if you're this age and you have a parent that has that, and if you smoke and you get this infection, so it's a little bit of a random type thing, but once it does affect you, it usually stays with you for the rest of your life.
Okay. It affects the joints. Does it affect certain ones more than others?
Most commonly, it affects the small joints of the hands and the feet. Also can affect the cervical spine, but it can't affect any joint. It can affect the knee joints and the shoulder joints, and even the hip joints.
Okay. You had mentioned a few risk factors. Are there other things that increase someone's risk for developing RA?
Smoking seems to be the biggest one. And we mentioned hereditary. If you have a family member who's had it, that increases your likelihood. The other things, in terms of exercise, lack of exercise, obesity, there really does not seem to be a good correlation.
Okay. So if someone thinks, well, I might have this, what course of action should they take? Because you're a surgeon, there's a rheumatologist. Do people typically start with their family practice physician and go from there?
Most often, I would say they do see their primary care physician. And I end up seeing some of them because they get referred to me for pain in their hands or swelling in their hands or arthritis, because I probably am more accessible than rheumatologists are today. And I will take a history and I'll examine them, and I will often initiate the initial laboratory testing. And if that's confirmatory or I'm uncertain, then I will usually refer them to a rheumatologist for further evaluation and workup.
Okay, so as a rheumatologist, that is all they study and deal with is RA?
No, they deal with all forms of arthritis, but more often they're involved with the inflammatory arthritis, but they do also overlap with orthopedic surgeons and care for patients who have osteoarthritis.
Okay. What are the long-term effects if people don't seek any treatment for it? What can happen over the course of time?
Rheumatoid arthritis follows a variable course.
Okay.
Some people, it can be episodic, where they'll have a flare-up and then things will quiet down and may or may not flare up again. That would probably be less likely be rheumatoid arthritis. But left untreated, the disease typically marches on with progressive destruction of the joints, subsequent loss of function, certainly deformity. People think of people with rheumatoid arthritis
as having a real big knuckles or kind of deformed hands.
Absolutely. The big knuckles and the fingers kind of drifting off to the side is kind of everybody's picture of rheumatoid arthritis. And so there can be progressive loss of function associated with deformity.
Okay. You talked about flare-ups, and I think anybody that deals with rheumatoid arthritis or arthritis just talks about flare-ups. Are there things that might bring those flare-ups on that your patients have told you about?
Again, it tends to be more patient dependent, but I actually have a daughter who's in her late 20s who does have rheumatoid arthritis, and I know while she was in school during the time of finals and that sort of thing, it always used to flare up on her. So there's always been a feeling that stress, fatigue, probably, as they say, cigarette smoking can do it. So they're poorly understood factors, but they are appreciated as things that if you can moderate, you probably experience less severe and less frequent flare-ups.
Okay. So for people who have RA, they know what their flare-ups are like, but maybe for someone like me that isn't around that, or maybe someone who has a loved one, explain to us what a flare-up is like and the level of pain and discomfort that a patient is going through.
It can be quite severe. I mean, where we can avoid narcotic medications, sometimes it does require narcotic medication. There typically is kind of an overwhelming sense of fatigue, significant morning stiffness that may take an hour or more to resolve. Just being able to, make a full fist with your hand, or to even be able to walk comfortably on your feet. The joints will those that are involved will typically become more swollen, which can be, quite visible, and they'll often become warm and red.
So are there some at-home treatments that people can try first before maybe needing more advanced, narcotics that you said?
Well, probably the first thing most people reach for is one of the anti-inflammatory medications. So Aleve or Advil, or if it's been prescribed, your Celebrex, and those types of medications. Aspirin is still frequently used to treat children with rheumatoid arthritis. Was really one of the original medications used to treat rheumatoid arthritis. Tylenol can help and can be taken in conjunction with one of the anti-inflammatory medications, but if it's persistent or seems to be getting worse, then that would prompt me to recommend that people see their primary care doctor or ask to make an appointment with an orthopedic surgeon or a rheumatologist. But usually a rheumatologist is not necessarily going to see them without a referral.
Okay. So will someone, after they've had the disease for so many years, will they get more flare-ups or as time goes on, or not?
Not necessarily.
Okay.
And with the newer medications today, flare-ups have actually become less severe and less frequent, and we're seeing much less severe destruction or damage to the joint surfaces. That's our goal, is to prevent the the functional limitations and the deformity.
So when if people have persistent flare-ups, it's the flare-up that eventually is causing the degeneration after a while?
There is a correlation with the frequency and the severity of flare-ups with damage to the joint surface.
Okay. I had a question here, and I should have asked it. I was doing my research. I understand that there's 2 different types of RA.
Well, there's probably many more than 2 types of RA, but just because of laboratory tests and kind of traditionally, and it does help us kind of determine prognostic factors, is one of the earliest tests for rheumatoid arthritis was something called the rheumatoid factor. And still today, if you see me or see a rheumatologist or even your primary care doc, and they're concerned about it, that's probably one of the first tests that they're going to run is a rheumatoid factor. And we alluded to that before, that about 70% of people with rheumatoid arthritis do have a positive rheumatoid factor. There are those that do not have a positive rheumatoid factor. We call those people seronegative. Now we know that the people who have a positive rheumatoid factor, particularly at higher levels, that there is a correlation there with the severity of the disease. And also with the newer tests, the antibodies, there is a correlation with that and the amount of that. So that, and just because you may start off as seronegative, a year or so after the diagnosis, it then may convert to positive. So it's kind of an arbitrary designation, but it does help us kind of provide people with expectations in terms of their prognosis.
Okay. So when you're doing all these diagnostic tests, do you use x-rays, MRIs, CT scans to look at the joint? What's the most common practice?
All of them have their place, but for rheumatoid arthritis, I would say the most common are plain x-rays. There are characteristic changes, loss of bone density around the bones next to the joints. You can see actually the soft tissue swelling. In more advanced rheumatoid arthritis, you will actually see loss of the space between the 2 ends of the bone, and there often will be irregularities. And one of the things that helps distinguish osteoarthritis from rheumatoid arthritis is, at least by x-ray, is with osteoarthritis, you typically see the development of what we call spurs or osteophytes, which they appear on x-rays as bony prominences. They tend to be conspicuously absent on the x-rays of patients with rheumatoid arthritis. You'll see loss of the joint space without a lot of the bony response to the arthritis like we see with osteoarthritis.
Okay. Now, I want to ask about exercise and movement and things like that. I mean, if you have RA, you may not want to go, I think I want to go, for a walk or jog or ride bike, but can exercise be good or sometimes bad for RA patients?
It definitely is beneficial.
Okay.
Because it keeps the muscle strong, which provides the support for the joint. It also serves to keep the surfaces kind of polished and smooth, and it also stimulates the body to secrete increased lubricating fluid. So it can be beneficial. I'm not aware of studies that show that it's associated with flare-ups, but we do recommend in rheumatoid arthritis where they can do lower impact activities such as swimming or riding a bike. That's preferential to something like running or jumping or weight-bearing activities.
So what about, weight-bearing activities in terms of like lifting weights and things like that? Is that good or bad?
I would say it's good.
Okay.
But again, light weights, higher repetition.
Okay.
again, to try to preserve the function and the range of motion, and just that sense of well-being.
Okay, so keep up the exercise.
Absolutely.
But talk to your doctor first about what might be
Well,
there.
and keep your weight down.
Yes.
And one means to
Well,
do that is consistent exercise.
That's true. Are there any kinds of dietary things or food things that are good for RA patients? Or nutritional supplements, vitamins, that sort of stuff?
There are a whole host of things that are promoted out there, but none of them that have been truly proven to have a significant impact.
Okay. But for general health, eating a good, healthy
Yes.
diet is
Yes.
always a good
Yep.
idea.
Absolutely.
So I mean, we see it on TV. There's ads all the time for new medications. Are the medications for RA getting better and better and helping people?
Oh, there's been huge changes within the last probably 8 to 10 years that have significantly improved the quality of life of people with rheumatoid arthritis.
Is it typically an injection sort of medication? I have a friend that has it, and that's what she takes.
Yes, there are a couple of medications. Imbral is one of them, which are used for other autoimmune diseases as well. Psoriatic arthritis crosses over with rheumatoid arthritis a little bit. Humira is another one. Those are both, at this point in time, by injection. I am not aware of any medications that are in that class that can be taken by mouth at this point in time.
So in this last minute or so, just give us a little bit of advice for someone out there who's living with RA, maybe having a hard time with it. You've probably had patients that are doing well. What advice would you give to someone?
Two things that the patient can actively moderate is, one, their smoking, and unfortunately that includes marijuana, and two, is their weight.
Okay.
And, seek out a professional that you can establish a good working relationship with, because unfortunately, unlike a broken leg, you're going to be entering into a long-term relationship with the physician who's going to be treating you for rheumatoid arthritis. And again, the nature of the problem is one that it can flare up without, predictable problems arising. And so you want somebody who will be attentive to you, that you can get in touch with relatively easily, and is going to be there to optimize your care. And, that's those taking responsibility for yourself, exercising, not smoking, keeping your weight down, and then, developing good rapport and a long-term relationship with a physician who you trust are going to be the biggest factors with long-term care of rheumatoid arthritis.
All right. Well, Dr. Rowe, our time went so fast. Thank you so much for shedding some light on RA, and hopefully it can help some people out there.
I hope it does.
Thank you.
Thanks, Lori.
When it comes to prescriptions, following your doctor's orders is critical. Despite that, some patients are not adhering to those instructions, and that can make feeling better harder. Susan Hendricks explains.
Whether you use over-the-counter or prescription medicine, it most likely means you're looking for something to make you feel better. Following instructions for your medication is a big deal.
If you veer from the plan that you and your physician have come upon and agreed upon, then you're not going to get the result that should have been there.
Pharmacist Rich Tomalevich says that applies to most medications.
In antibiotic therapy, the infection may never go away. Antidepressant therapy, you truly never may get to what's called steady state, and it may never be truly effective. Blood pressure medication may truly never work.
Research shows that 50% of Americans don't take their medicine as prescribed, and the ramifications can be significant. Non-adherence to medication guidelines causes 30 to 50% of treatments to fail and 125,000 deaths annually.
For anything to truly work the way you want it to, you have to give it a true shot. You have to give it a chance.
Toma Levich says if you miss a dose, ask for help to get back on track.
That's what a pharmacist is for. A pharmacist is there to answer your questions specifically because it truly depends on the medication.
For today's Health Minute, I'm Susan Hendricks.
That's all the time we have for this edition of Being Well. Check us out right here on WEIU TV Tuesday evenings at 7 and Wednesday afternoons at 12:30 or anytime on YouTube. You'll find new programs there as well as extra program content from some of our guests. Until next week, I'm Lori Casey for Being Well. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles. Eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. AlphaCare, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. AlphaCare, compassionate professional home care. Additional funding by Jazzercise of Charleston.